my dear friends. Now, as a part of the continuation of the endocrinology, in this session we will be discussing a very important topic, that is prolactinoma. So, before going on to the discussion of the topic of prolactinoma, first let me take up the discussion of the physiology of the prolactin. So, if you take this particular hormone prolactin, it is the hormone which is secreted from anterior pituitary. And the other hormones from the anterior pituitary, they include the following. And these anterior pituitary hormones are: number 1, adrenocorticotrophic hormone, then thyroid stimulating hormone, next we have luteinizing hormone, follicle stimulating hormone, then prolactin, what we are discussing now, right? So these are the hormones, and then we have TSH, thyroid stimulating hormone. So these are the hormones which are secreted from the anterior pituitary, and one among that is your prolactin. And if you take the regulation of the prolactin secretion, remember prolactin is under the predominant inhibitory control of the hypothalamus. So all your anterior pituitary hormones, they are completely under the control of the hypothalamus. So hypothalamus, it is connected to the pituitary gland through a stalk, and that particular stalk is called hypothalamo-hypophyseal tract. Right, that particular stalk is called hypothalamo-hypophyseal tract, or this is also called infundibulum. So this hypothalamo-hypophyseal tract or infundibulum, that will be the pathway for the hormones which are secreted in the hypothalamus that will go and act on the anterior pituitary. The anterior pituitary will secrete the hormones in response to your hypothalamus. And if you take the prolactin, this particular prolactin is under predominant inhibitory control of the hypothalamus. So we have the dopamine. So this particular dopamine, whichever is synthesized from the hypothalamus, it will inhibit the secretion of the prolactin. So prolactin is under predominant inhibitory control of the hypothalamus through prolactin releasing inhibitory hormone. And what is that prolactin releasing inhibitory hormone? That prolactin releasing inhibitory hormone is nothing but your dopamine, right? And remember, this particular dopamine, it goes and acts on the pituitary lactotrophs. Right, it goes and acts on the pituitary lactotrophs. And you have the receptors on the pituitary lactotrophs, that is D2 receptors. And this dopamine, by acting on D2 receptors, that will inhibit the prolactin secretion. So that means that if dopamine is not there, the prolactin will be secreted. If dopamine is synthesized from the hypothalamus, then prolactin is not secreted. So always remember this very important point. In a normal individual, prolactin is under predominant inhibitory control in a normal individual. What are the conditions where the prolactin will be increased? That all we will be discussing in the further part of the session. Now, from this particular lactotrophs or from the pituitary gland, there are various tumors that can originate. Now, let me just tell you what are the conditions where you will have hyperprolactinemia. And this particular hyperprolactinemia, it can be physiological hyperprolactinemia, and then we have pathological hyperprolactinemia. Right, physiological hyperprolactinemia and as well as the pathological hyperprolactinemia. Now, what are those physiological conditions and what are those pathological conditions? Let me tell you that. So first, you take this question, which of the following is the most common type of pituitary adenoma? Thyrotropinoma, gonadotropinoma, prolactinoma, corticotropinoma. Now, among the tumors of the pituitary gland, the most common secretory tumor that will be prolactinoma. So please remember, prolactinoma, it is the most common secretory tumor. Right, it is the most common secretory tumor of the pituitary gland. Now, there are like various cells in the pituitary gland, right? Depending upon what is the origin of that particular cell, accordingly the hormone is being produced. Like for example, you take the various tumors of the pituitary gland. For example, if the tumor is originating from the lactotrophs, it will produce prolactin and there will be hyperprolactinemia and the individual will have the hypogonadism and as well as the galactorrhea. So for this, you need to know the physiology of the prolactin. What we have discussed until now, I have just taught you only where the prolactin is secreted and what is the hormone which is regulating the prolactin secretion. But let me tell you that what is the physiological actions of prolactin in males and as well as females. In females, prolactin is very much required for lactation, and the next very important point is the prolactin in females will also inhibit the ovulation, and prolactin in females will also inhibit the menstruation. So that is the basic physiology of prolactin in females. Whereas you take the basic physiology of prolactin in males. If you take the physiological actions of prolactin in males, it will inhibit the testosterone production, and the prolactin will also inhibit spermatogenesis. So this is the physiological action of the prolactin in males and as well as the females. So now accordingly, in case of hyperprolactinemia, what will happen? There will be hypogonadism and as well as galactorrhea. And for suppose, if the tumor is originating from gonadotroph cells of the pituitary adenoma, then it is called gonadotroph type of pituitary adenoma, where there is excessive production of follicle stimulating hormone and luteinizing hormone, and accordingly the individual will have the manifestations. And if the tumor is originating from somatotroph type of cells of pituitary gland, that will result in somatotropinoma. This particular somatotroph type of pituitary adenoma will produce excess amount of growth hormone, and this excess amount of growth hormone will lead to acromegaly or gigantism. And if the tumor is originating from corticotroph type of cells, right, if the tumor is originating from corticotroph type of cells, that will result in corticotroph type of pituitary adenoma, where there is excessive production of ACTH, and that will result in what is called the Cushing syndrome. So depending upon the type of cell from which the tumor is originating, like for example, we have what is called mammosomatotroph type of pituitary adenoma. That means mammosomatotrophes, these cells, they will produce prolactin and as well as the growth hormone, right? Prolactin and as well as the growth hormone. So mammosomatotroph type of pituitary adenoma is the one which will produce excess amount of prolactin and as well as the growth hormone, and accordingly the individual will land up in galactorrhea, acromegaly and as well as the hypogonadism. And if the tumor is originating from thyrotroph cells of your pituitary gland, that will result in the thyrotroph type of pituitary adenoma, where there is excessive production of thyroid stimulating hormone, and that will result in thyrotoxicosis, right? That will result in thyrotoxicosis. So these are the cells of origin for the development of the tumor, and accordingly you have the respective clinical manifestations. Now out of this, the one which we are going to discuss now in detail is about the prolactinoma. So prolactinoma, it is the most common type of secretory pituitary adenoma, right? So if you see this, the most common tumors which is originating from the pituitary gland is your prolactinoma. It will be seen in almost in 50 to 60% of cases. And the next most common is your somatotroph type of pituitary adenoma, where there is excessive production of the growth hormone resulting in acromegaly. And the next one is corticotrophinoma, where there is excessive production of ACTH resulting in Cushing's. And the other type of the pituitary adenoma which are common is the gonadotroph type of pituitary adenoma, right? But if the question is asked, what is the most common pituitary adenoma? Like if they mention the word most common pituitary adenoma, remember the answer is not prolactinoma, right? So please don't get confused. I'll tell you. Most common secretory pituitary adenoma, then it is your prolactinoma. Whereas most common pituitary adenoma, it is non-secretory tumor of the pituitary. Right, non-secretory tumor of the pituitary. Okay. Now, having discussed about the tumors originating from the pituitary gland, now let me discuss about this particular prolactinoma. Prolactinomas, as I have said you, they are the most frequent type of hyperfunctioning pituitary adenoma, and they account for nearly around 50 to 60% of these pituitary adenomas. Now, this pituitary adenoma, which is nothing but prolactinoma, depending upon the size of the tumor, right, depending upon the size of the tumor, we classify that into microadenoma, and as well as macroadenoma. So you take microadenoma. Microadenoma, the size of the tumor is less than 10 mm. Macroadenoma, the size of the tumor is more than 10 mm. But between these two, which are more common in case of your prolactinoma? Microadenoma is very common than compared to that of your macroadenoma. Now, having discussed about this, now let me discuss what are all the various causes for the hyperprolactinemia. So, if you take the various causes of hyperprolactinemia, okay. So, before that, which of the following is the most common type of pituitary adenoma? Just now we have discussed, that is prolactinoma. Now, you take the next question. All are the causes of hyperprolactinemia except bromocriptine, phenothiazines, methyl dopa, metoclopramide. So, what is that we are discussing now? The causes of hyperprolactinemia. And in this question, he is asking you which is the drug which will not cause hyperprolactinemia. So first, let me tell you what are the physiological causes, and then I will also discuss the pathological causes for hyperprolactinemia, wherein I will discuss the drug which will not cause hyperprolactinemia. Now you take the physiological causes of hyperprolactinemia, that includes pregnancy, lactation, right? Then followed by that, chest wall stimulation, sleep, and then stress. So these are the physiological causes for hyperprolactinemia. Now, after having discussed about the physiological causes, let me discuss the pathological causes for hyperprolactinemia. So pathological causes, if you take, either you take the tumors or the pituitary hypersecretion, that can occur in clinical scenarios of prolactinoma. Right, that can occur in scenarios of the prolactinoma. So in prolactinoma, there will be, this is the most common pathological condition where the individual can have hyperprolactinemia. Then followed by that, the systemic disorders. Systemic disorders include chronic renal failure, See, why in case of chronic renal failure there will be hyperprolactinemia? Why? Because the prolactin which is synthesized from anterior pituitary has to undergo metabolism and then get excreted through the kidney. And if there is kidney failure, right, if there is renal failure, the prolactin, it gets accumulated within the body and that will result in hyperprolactinemia. So that is one of the systemic disorder. And the next important condition is hypothyroidism. Right, the next important condition is hypothyroidism. So you take in patients with the primary hypothyroidism. Right, you take in patients with the primary hypothyroidism. So in primary hypothyroidism, please remember there is excess production of thyroid releasing hormone from hypothalamus. Right, there is excess release of thyroid releasing hormone from the hypothalamus, and this excess thyroid releasing hormone whichever is released, right, this excess thyroid releasing hormone whichever is released from the hypothalamus will go and act on the anterior pituitary, and anterior pituitary will produce both, right, anterior pituitary will produce both. What is that? Thyroid stimulating hormone, and as well as the prolactin is also produced in excess quantities, right, as well as the prolactin is also produced in excess quantities. So in hypothyroidism, primary hypothyroidism, there will be hyperprolactinemia because of excessive release of thyroid releasing hormone from the hypothalamus. This thyroid releasing hormone will act on anterior pituitary resulting in hyperprolactinemia. Next, coming to the drugs causing hyperprolactinemia. See, drugs causing hyperprolactinemia mainly they are dopamine antagonists or dopamine receptor blockers, because if dopamine is there, the prolactin levels will be suppressed. But if dopamine is not there or if dopamine action is not there, then there will be hyperprolactinemia, right? So accordingly, what are those particular dopamine antagonists or dopamine receptor blockers? So the drugs include risperidone. So risperidone, please remember, it is atypical antipsychotic, right? Atypical antipsychotic. Then we have metoclopramide. So metoclopramide, it is an antiemetic. This can also cause hyperprolactinemia. Then we have cimetidine. So cimetidine, it is H2 receptor blocker. Right, it is an H2 receptor blocker. Then we have dopamine synthesis inhibitors. And these dopamine synthesis inhibitors include, so dopamine synthesis inhibitors, they include methyl dopa. Right? So these are the drugs which will cause the hyperprolactinemia. Now, so if you go back to the question here now, all are the causes of hyperprolactinemia except your bromocriptine. Bromocriptine, it is a dopamine agonist. Right, bromocriptine, it is a dopamine agonist that will go and act on the D2 receptors and it will inhibit the prolactin production. So bromocriptine, in fact, it is given in the treatment of prolactinoma, right? So it is a dopamine analog that acts on the D2 receptors and it will inhibit the prolactin secretion, right? Now, after having discussed about the conditions causing hyperprolactinemia, now let me discuss the prolactinoma per se. So you see this question here. A 30-year-old woman presented with secondary amenorrhea for 3 years along with Galactorrhea. The most likely cause of her symptoms would be craniopharyngioma, prolactinoma, meningioma, subarachnoid hemorrhage. See, the answer to this question is the prolactinoma, and this is how the questions can be asked. Now, let me discuss in detail about the prolactinoma. As already I have said you, that depending upon the size of the tumor, the prolactinomas, we classify that into microadenoma and as well as the macroadenoma. Microadenoma, the size of the tumor is less than 10 mm. The macroadenoma, the size of the tumor is more than 10 mm. Right? Now, let me discuss the clinical features in prolactinoma. But before going on to the clinical features of prolactinoma, you should know the anatomy of the pituitary gland. Now, why is that you should know the anatomy of the pituitary gland while we are discussing prolactinoma? Why? Because you see, in case of microadenoma, you don't have any mass effect on the surrounding structures. You will have only endocrine manifestations. Right? You will have only endocrine manifestations. And in case of macroadenoma, you will have both endocrine manifestations plus mass effect on the surrounding structures. Right, plus mass effect on the surrounding structures. Now, let me discuss the basic anatomy. Only until unless you understand the anatomy of the pituitary gland, that is when you will understand about this particular mass effect. Now, so if you take the anatomy of the pituitary gland, it is placed within the sella turcica. Now, what is this particular sella turcica? Sella turcica, please remember, it is a saddle-shaped depression within the sphenoid bone, right? So, this is the sphenoid bone. So, within the sphenoid bone, this is a saddle-shaped depression. And this particular saddle-shaped depression, right? This particular saddle-shaped depression, it forms the caudal border of the pituitary gland, right? This forms the caudal border of the pituitary gland. And this sella turcica, it is an anatomically complex area with a number of different potential pathologies, especially the neoplastic processes. So within this particular sella turcica where you have the pituitary gland, there are a number of the neoplastic processes which can originate. Neoplastic processes are nothing like you have various cells, you have lactotrophs, there can be a tumor originating from lactotrophs. You have gonadotrophs, there can be a tumor originating from gonadotrophs within the pituitary gland. You have somatotrophs, you have corticotrophs, you have thyrotrophs, you have mammotrophs. So from any of these particular cells, the tumor can originate within the pituitary gland, right? Now, the other important thing is the pathologies of this particular sella turcica. This can lead to important clinical presentation such as the hormonal imbalances from pathologies which are affecting the pituitary gland, and the pathologies which are originating from sella turcica can also cause the mass effect, right? And this particular mass effect is due to compression on the surrounding structures, right? So this sella turcica, please remember, it is critically located as several structures pass close to it due to compression of the adjacent structures, right? It is critically located. I'll just tell you now what are the surrounding structures around the sella. Very simple now. When the pituitary gland is enlarging within the sella turcica, the pituitary gland, whichever is enlarged, it can cause the compression on the surrounding structures. Now you should know what are those surrounding structures. Now, so if you take the surrounding structures, these are all the surrounding structures around the sella. That includes the optic chiasma. So what is this particular optic chiasma? It is nothing but the crossing of your optic nerves, right? So this is your optic chiasma, right? Next, the second important structure in the pituitary gland, in the sella turcica is the pituitary gland itself. And surrounding that particular sella turcica, you have the cavernous sinus. Right, you have this cavernous sinus. So within this cavernous sinus, you have the presence of the cranial nerves and as well as the internal carotid artery, right? Cranial nerves and as well as the internal carotid artery. And these cranial nerves, they include 3, 4 and as well as 5. So these are the cranial nerves which are present on the lateral wall of the cavernous sinuses, and whenever the pituitary gland is enlarging, it can cause the compression on the surrounding structures. And you also have the sphenoid sinuses. These are the sphenoid sinuses. So these are the surrounding structures around the sella. And whenever the pituitary gland is increasing in its size, it can cause the compression on all these structures, resulting in the clinical manifestations. Now, you should know what are all the various masses which can originate from the sella. And they are called as the cellular masses. They are the following. So, these cellular masses can be neoplastic, these cellular masses can be cystic, these cellular masses can be infectious and inflammatory, and some other masses. You take the neoplastic masses. So, neoplastic masses, if you take, that includes the pituitary adenoma, meningioma, the tumor which is originating from the meninges, craniopharyngioma, that is a tumor which is originating from rat case pouch, germ cell tumor, and as well as the metastatic disease. So these are the neoplastic masses, right? These are your neoplastic masses. Then we have cystic lesions. Now what are these cystic lesions? That includes the rat case cleft cyst. So rat case cleft cyst is nothing but it is the tumor which is originating from the remnants of the rat case pouch. Then we have arachnoid cyst and dermoid or the epidermoid. These are the cystic lesions which constitute the cellular masses and which can cause the compression on the surrounding structures. Then we have infectious and as well as the inflammatory conditions. Now, the infections, that is the infection of the pituitary gland, that is your pituitary abscess. Then lymphocytic hypophysitis. What is this lymphocytic hypophysitis? It is an autoimmune condition where the hypophysis cerebri, that is your pituitary gland, is infiltrated by your lymphocytes. That is called lymphocytic hypophysitis. Then you take granulomatous hypophysitis. It is the same thing again. It is the infiltration of the granulomas into the hypophysis cerebri, which is nothing but your pituitary gland. And this granulomatous hypophysitis, you can have this in sarcoidosis, right? So you can have this in tuberculosis. You can have this in syphilis. So these are the conditions where you will have the granulomatous hypophysitis. Now you take the other masses, other cellular masses. That includes aneurysm, the pituitary hematomas, and as well as the pituitary hyperplasias. See, these are all the cellular masses which can cause the compression on the surrounding structures. So these cellular masses, they may remain asymptomatic and they are found incidentally, like they are called as incidentalomas. Or these particular cellular masses can cause hormonal imbalance. Like you take the pituitary adenoma, it can cause hormonal imbalance. Or these particular cellular masses can cause the neurological symptoms as well. Now what are those? You take incidental finding. In almost 2.7% of autopsy studies, you will have this asymptomatic pituitary microadenomas. So this asymptomatic pituitary microadenomas, they are found incidentally and they are called as incidentalomas. That is one of the presentation of your cellular mass. And you take this pituitary adenoma. In the pituitary adenoma, it can be lactotroph type of pituitary adenoma where there is excessive production of prolactin. It can be somatotroph type of pituitary adenoma where there is excessive production of the growth hormone. There can be corticotroph type of pituitary adenoma where there is excessive production of ACTH. And it can be thyrotroph type of pituitary adenoma where there is excessive production of the TSH, that is thyroid stimulating hormone. And there can be gonadotrophinoma. right, where there is excessive production of FSH and as well as LH. So accordingly, you will have this particular hormonal imbalance as well. Then followed by that, the neurological symptoms. Neurological symptoms are basically because of the mass effect on the surrounding structures. Please remember, as a part of the mass effect, the individual can have headache because of raised intracranial pressure. The individual can have the cranial nerve symptoms from the compression of the cranial nerves within the cavernous sinus. And there can be classical visual disturbances. And why is that? That is because of the compression of your optic chiasma. So these are your classical visual disturbances. So these are the presentation of the cellular masses, right? These are your presentation of cellular masses. Now out of this, let me discuss the prolactinoma. Right? Out of this, let me discuss the prolactinoma. So if you take the clinical features of prolactinoma, right? You take the age group. Most common age group in which you will have these prolactinomas are around 20 to 30 years of age. And these prolactinomas, most commonly they are microadenomas rather than the macroadenomas. And if you take the symptoms of prolactinoma, these particular symptoms include: number one, due to excessive hormonal production of prolactin, right? And number two, due to mass effect. Right, due to mass effect on the adjacent structures. So these are the symptoms of the prolactinoma. Now, coming to the mass effect and as well as the endocrine manifestations, both of that I will discuss. So first, let me take up the discussion of the mass effect. See, mass effect, it is mainly this prolactinoma, that is macroadenoma. It can cause the compression on the optic chiasma. Right? And which part of the optic chiasma this prolactinoma will compress? You consider this is your optic chiasma which is crossing. So optic chiasma is nothing but the crossing of your optic nerves. And in the optic nerve, you have the lateral fibers and you have the medial fibers. Medial fibers of the optic nerve, they cross, but lateral fibers of the optic nerve, they don't cross. Now, another important point is this prolactinoma, it is an infracellular tumor. Right, it is your infracellular tumor. So, what this prolactinoma will do is, it will cause the compression of the optic chiasma from below. Right, it will cause the compression of the optic chiasma from below, and that too in the central part. Right, so this central part of the optic chiasma will be compressed. Now, one important point you should remember is that the medial fibers of the optic nerve, they bring the vision from temporal side, right? So, it is your temporal vision which is brought by your medial fibers, and lateral fibers, they bring the vision from the medial half of the visual field. So temporal visual field is by your medial fibers and the medial part of the visual field is by your lateral fibers. So now your prolactinoma, that is macroadenoma, it is compressing the medial fibers. So your temporal vision is lost, right? And medial fibers of both the sides are damaged or compressed or destroyed. So that is the reason why the individual will have bitemporal hemianopia. Right, that is the reason why the individual will have bitemporal hemianopia. Right, that is one point. And the pituitary adenoma, that is prolactinoma, is compressing the optic nerve from below. So the fibers which are present below, they will bring the vision from the superior part of your visual field. So the clinical manifestations of the visual field includes bitemporal, superior hemianopia. So this will be the visual field defect that you will have in patients with the prolactinoma. So very simple. Why temporal visual field gone? Because the medial fibers are compressed. And why superior part of the visual field is gone? That is because the inferior fibers are damaged. And these inferior fibers of your optic chiasma or the optic nerve, they bring the vision from the superior half. Alright, they bring the vision from the superior half. Okay, so these are about the symptoms due to the mass effect. And not only that, whenever there is macroadenoma, there will be raised intracranial pressure. So because of this particular raised intracranial pressure, the individual can have optic atrophy. Right, the individual will develop optic atrophy. So that is about the macroadenoma. Now, in case of microadenoma, what is that you will have? You will have endocrine manifestations. Now, what are those endocrine manifestations you will have? So, whenever there is increase in prolactin, you will have the hyperprolactinemia or prolactinoma can occur either in males or females. So, in females, what will be the manifestations? In females, the manifestations include Galactorrhea and as well as the amenorrhea. So Galactorrhea, amenorrhea, that is the clinical presentation in females if there is hyperprolactinemia. And not only that, there is also inhibition of the ovulation. Because of the inhibition of the ovulation, the individual will have infertility. Right, the individual will have infertility because of the inhibition of the ovulation. Next, you take in males. Right, you take in males. So, in males, what will be the presentation because of hyperprolactinemia? What is that we have discussed in the basic physiology? The prolactin, it will inhibit the testosterone production. So, there will be loss of libido. And the other important basic physiology we have discussed that the prolactin, it will inhibit spermatogenesis. So, the individual will have infertility. Right, the individual will have infertility. So, these are the manifestations because of your hyperprolactinemia in males or females. And this clinical manifestations of hyperprolactinemia can be seen in microadenoma and as well as the macroadenoma. Right, can be seen in microadenoma and as well as the macroadenoma. So, these are the clinical manifestations in prolactinoma. One is due to mass effect, that is bitemporal superior hemianopia, and then the endocrine manifestations, that is Galactorrhea, amenorrhea, infertility in females, loss of libido and as well as infertility in males. Now, going back to the same question, a 30-year-old woman presented with secondary amenorrhea for 3 years along with Galactorrhea. The most likely cause of her symptoms could be that is your prolactinoma. So now you can correlate after the discussion of the clinical manifestations. And this is the summary, right? That is symptoms due to mass effect and as well as the endocrine manifestations in patients with your prolactinoma, right? And you can see the visual field loss, that is bitemporal right? Bitemporal superior hemianopia, right? Now, after having discussed about the clinical scenario of prolactinoma, I'll just ask you one more question. So we have a 35-year-old female presenting with 1 year history of menstrual irregularity and galactorrhea. She also has on and off headache, and her examination revealed bitemporal superior quadrantanopia. Her fundus examination showed primary optic atrophy. Which of the following is the most likely diagnosis in this case? The options are craniopharyngioma, pituitary macroadenoma, ophthalmic artery aneurysm, chiasmal glioma. So you see here 35-year-old women complaining of amenorrhea and as well as galactorrhea along with visual field defects. So this will confirm it is a macroadenoma. And which type of macroadenoma it is? It is your prolactinoma. Why is that prolactinoma? Because of the galactorrhea and as well as the menstrual irregularity which is present within the individual. So amenorrhea and galactorrhea, they result from increased secretion of this prolactin. The headache and visual field defects, they are seen due to mass effect of the tumor on the optic nerve. And one of the very important close differential diagnosis of your prolactinoma is your craniopharyngioma, right? Craniopharyngioma is one of the close differential diagnosis because even craniopharyngioma also you will have the visual field defect. But the point is craniopharyngioma will never produce amenorrhea galactorrhea. Right, in craniopharyngioma, there is no amenorrhea and as well as the galactorrhea. Right, there is no amenorrhea and as well as galactorrhea. Right, and please remember, craniopharyngioma does not secrete any hormone. Right, does not secrete any hormone. Okay, so the close differential diagnosis for your prolactinoma is your craniopharyngioma. And if you take the features of your craniopharyngioma, so please remember this particular craniopharyngioma, first of all, it does not produce any hormone that I have discussed in my previous slide. And if you take the age of presentation, bimodal age of incidence is there. And what do you mean by this bimodal age? One peak is in childhood, right? And the other peak is in the old age. So that is what is called as the bimodal age of presentation. And not only that, these craniopharyngiomas, they are supracellular tumors, whereas your prolactinomas, they are infracellular tumors. So this being in supracellular tumor, what will be the symptoms due to this craniopharyngioma? This will also have bitemporal inferior quadrantanopia. Right, bitemporal inferior quadrantanopia, right? So that will be the clinical presentation in patients with the craniopharyngioma. But you will not have any endocrine manifestations in craniopharyngioma. And what is your craniopharyngioma? Craniopharyngioma, it is mainly the tumor which is originating from your rat case pouch, that is from your hypothalamus. So mainly you will have only mass effect in the craniopharyngioma on the optic chiasma. So that is bitemporal inferior quadrantanopia. And because of raised intraocular pressure, there can be optic atrophy and there can be also the papilledema as well. So what is this papilledema? It is your swelling of the optic disc. Right? So swelling of this particular optic disc is nothing but your papilledema. And in this craniopharyngioma, there will be also raised intracranial pressure. So due to which the individual will have the headache and as well as vomiting. right? And this craniopharyngioma can also cause the compression on the pituitary gland, right? And that is mainly over the posterior pituitary, and that will result in diabetes insipidus, right? And the individual will also have the psychological and as well as the mental retardation as well. So these are the clinical manifestations in patients with your craniopharyngioma. Now, after having discussed about the clinical manifestations in prolactinoma and one of the differential diagnosis craniopharyngioma, now let me discuss the investigations in patients with your prolactinoma. So, after the completion of the discussion on the clinical features in prolactinoma, now let me tell you the investigations. How do you investigate these patients with the prolactinoma? So, investigation of choice of hyperprolactinemia is thyroid releasing hormone estimation, luteinizing hormone estimation, prolactin estimation, estradiol estimation. So, always remember one of the very important point in the endocrinology, always first it is your chemical analysis. So, the investigation of choice in hyperprolactinemia is your prolactin estimation. So, hyperprolactinemia is common in young women and plasma prolactin should be measured in women with amenorrhea whether or not galactorrhea is present, right? If there is amenorrhea, right, you can test for the presence of hyperprolactinemia in a young woman. And always remember, whenever you are testing for the prolactin levels, right, you have to test for fasting morning sample, right? So you have to test for the fasting morning sample. Okay, and what is the normal prolactin levels, right? The normal prolactin levels are 5 to 20 nanograms per deciliter. That is the normal levels of your prolactin levels. And one of the very important point that you should remember is that the hormone secretion is pulsatile, right? It is not, like continuous secretion of the prolactin will not be there, right? The hormone secretion is pulsatile and very widely. Therefore, it is necessary to measure hormone levels on several different occasions. Why? Because the hormone secretion is pulsatile. Okay, intermittently there will be a spurt of release of your prolactin. So that is the reason why you have to test at different occasions. Now, so as I have said you, the normal prolactin levels are 5 to 20 nanograms per deciliter. And what is the levels of the prolactin in patients with the prolactinoma? So, in case of the prolactinoma, the levels should be more than 200 nanograms per deciliter. So, when the levels are more than 200 nanograms, that is the point when we use the terminology called prolactinoma. So, in prolactinoma, the levels should be more than 200 nanograms per ml. Now, for suppose, if the levels are in between 100 to 200 nanograms per ml, then it is considered as strongly suggestive of prolactinoma, right? We cannot confirm prolactinoma, but this will strongly suggest prolactinoma. Right, so that is about like when the levels are in between 100 to 200 nanograms per ml. Now, when the levels are less than 100 nanograms per ml, then it is due to any cause except prolactin secreting adenoma. Right, so it might be, right, so when the levels are less than 100 nanograms per ml, it might be due to any cause except the prolactin secreting adenoma. So this is about your prolactin levels. So investigation of choice in case of hyperprolactinemia is your prolactin estimation, right? Now, having discussed about this, let me take up one of the very important question: how do you treat these patients? Okay, but before the treatment, one more point what I want to tell you is, after estimating the prolactin levels, the next important investigation what you have to do is MRI. If the levels are more than 200 nanograms per ml, the next important investigation what you need to do is MRI. Now, what is the purpose of doing the MRI of the pituitary gland? By doing the MRI of the pituitary gland, if you are suspecting prolactinoma, you have to look for the size of the pituitary gland. You have to make out whether it is microadenoma or whether it is macroadenoma, right? So microadenoma, as I have said you previously also, the size is less than 10 mm, whereas macroadenoma, the size is more than 10 mm, right? So that is what is the difference between your microadenoma and as well as the macroadenoma. Now, having discussed about the investigations, let me take up the treatment in patients with the prolactinoma. So, if you see the next question related to the treatment, we have a young woman with amenorrhea galactorrhea syndrome demonstrating a tumor of less than 10 millimeters diameter in the pituitary fossa. What is the treatment that you will give? Hormonal therapy for withdrawal bleeding, radiotherapy, chemotherapy, bromocriptine, and then surgery. Now, always remember one important point, whether the individual is having microadenoma or whether the individual is having the macroadenoma. Please remember, the drug of choice or the first line treatment is your bromocriptine, right? The first line treatment is bromocriptine, whether it is microadenoma or macroadenoma. Now, what is your bromocriptine? Bromocriptine, please remember, it is a dopamine agonist. And this bromocriptine, which is a dopamine agonist, will go and act on the D2 receptors which are present on the anterior pituitary. So, by acting on D2 receptors, right, by acting on D2 receptors, these particular dopamine agonists will inhibit, right, will inhibit the prolactin secretion. Okay, so that is about the mechanism of action of the bromocriptine. And not only that, under the influence of bromocriptine, even the tumor size decreases within days and the prolactin level falls and the visual field defect improves. That is what is the advantage of your bromocriptine. So, this particular bromocriptine, please remember, within days, it will reduce the prolactin levels, right? And the visual field defects improves. And even if you take the tumor size is decreased, right? Even the tumor size is decreased. So that is what is the treatment of prolactinoma, right? And for example, like when you're giving bromocriptine or you are giving bromocriptine, but the tumor size, right? But the tumor size, it is remaining same. Right, the tumor size is same, it is not reducing, or the prolactin levels still they are on the higher side in spite of giving bromocriptine. And what will be the next line treatment? The next line treatment will be surgical treatment. Right, the next line treatment will be surgical treatment. And what is that particular surgical treatment? That particular surgical treatment is transsphenoidal microsurgical approach, right? Transsphenoidal microsurgical approach with an attempt of removal of the tumors, right? With an attempt at the total removal of the tumors. So that is what is your transsphenoidal microsurgical approach, right? This transsphenoidal pituitary adenectomy, right? Pituitary adenectomy. Now you should know what are the indications for surgery in case of the prolactinoma. So please remember, whenever the individual is having dopamine resistance or when the individual is having dopamine intolerance, that is when you need to consider for surgery. And whenever there is presence of invasive macroadenoma, right, whenever there is presence of whenever there is presence of invasive macroadenoma with compromised vision, then in such case also you need to do the surgical resection. So invasive macroadenoma with compromised vision that fails to improve rapidly after the drug treatment, then you need to do the pituitary resection of, you need to do the surgical resection of the pituitary. And please remember, the medical management can be done with the help of bromocriptine, and the other agent which we have, which is also a dopamine agonist, is your cabergoline. So cabergoline, please remember, this is also a dopamine agonist which is given in the treatment of your prolactinoma. So if you summarize the treatment, treat initially with bromocriptine or cabergoline, which is a dopamine agonist, which will reduce the prolactin level in hyperprolactinemia, which will reduce the level of prolactin in hyperprolactinemia. And almost like 90% of the patients treated with bromocriptine or your cabergoline have a drop in the prolactin levels to less than 10% of the pre-treatment levels. But remember, if the individual is refractory to medical management, not responding to your cabergoline or bromocriptine, that is the point when you need to consider for surgery. Right? And next thing is radiotherapy. See, when do we use this particular radiotherapy? We need to use the radiation surgery if drug therapy and as well as surgery is ineffective at reducing the tumor size and as well as the prolactin levels. That is the point when we need to use this radiation therapy. So, I'll just teach you this particular management of prolactinoma in the form of a flowchart. So, if you see this flowchart here, so right, if you see that or if you find that there is elevated prolactin levels, what you need to do, you have to rule out the secondary causes of hyperprolactinemia, right? What are the secondary causes of hyperprolactinemia? You have physiological causes and pathological causes. Physiological causes like pregnancy, lactation, sleep, stress, chest wall stimulation. These are the physiological causes. Pathological causes like tumors like prolactinoma, systemic conditions like chronic renal failure and as well as the hypothyroidism. Drugs like cimetidine, metoclopramide, risperidone, these are the drugs. And then we have endocrine conditions like primary hypothyroidism. So all these causes have to be ruled out, or like you need to test for this particular individual etiology causing hyperprolactinemia. And if you are strongly suspecting prolactinoma, get an MRI done. Right? Get an MRI done. So just test whether the individual is having microadenoma or macroadenoma. Dear doctor, the spelling mistake you have done here, it should not be microadenoma, it should be macroadenoma. So please make this spelling mistake. Please correct this spelling mistake. So whether it is microadenoma or macroadenoma, the first line treatment will be your dopamine agonist itself. For suppose, when you are giving a dopamine agonist in microadenoma, you need to test for the serum prolactin levels after a period of time, and if the serum prolactin levels are less than 20 nanograms per ml, then continue your medical management whatever you are giving. So, if you see the treatment in case of the microadenoma, if the levels are less than 20 nanograms per ml, then continue the same treatment of the bromocriptine whatever you are giving. But if the levels of your prolactin is 20 to 50 nanograms per ml in spite of giving bromocriptine, that is the point when you need to increase the dose of the bromocriptine or cabergoline whatever you are giving to the patient. And if the levels of your prolactin levels are more than 50 nanograms per ml, that is the point when you need to consider for surgery. Right? That is the point when you need to consider for surgery. So that is the treatment in case of the microadenoma. But you take in case of the macroadenoma. Even in macroadenoma also we need to start with the same dopamine agonist itself. But please remember, after giving dopamine agonist, after 4 months you need to repeat the MRI. Right? You need to repeat MRI within 4 months. Okay. Now, once you repeat MRI within 4 months, what is that you need to test within the MRI? You have to test for the presence of the tumor shrinkage. Right? You have to test for the presence of the tumor shrinkage. If there is tumor shrinkage and if the prolactin level is getting normalized, right? If there is tumor shrinkage and if the prolactin level, if it is getting normalized, that is the point when you need to continue the same bromocriptine. But if there is no tumor shrinkage and if the prolactin levels are still on the higher side, that is the point when you need to consider for surgery. So this is the management of the prolactinoma, whether it is microadenoma or the macroadenoma. So this completes the discussion of your prolactinoma. So to summarize prolactinoma, it is the disorder which is commonly seen in young women of the age group around 20 to 30 years. And you need to know like what are the conditions which will cause physiological hyperprolactinemia and pathological hyperprolactinemia. And you take in case of males, usually they present with the loss of libido and as well as infertility. Whereas in females, they present with galactorrhea, amenorrhea and as well as the infertility. And the investigations are, the investigation of choice is the prolactin levels, right? And the treatment, if you see, bromocriptine is the drug of choice. And if the individual is refractory to your medical management, then you need to do transsphenoidal surgical resection of the pituitary tumor. So this completes the discussion of your topic related to prolactinoma. Thank you very much.